Good afternoon. I'm so pleased always to be invited to this meeting, and it's always an honor that you all stayed when it's one of the nicest, warmest days that we could imagine. So again, my name's Beth Faiman. I'm a nurse practitioner and a PhD candidate from Cleveland Clinic in Cleveland, Ohio. And I'm going to talk about managing adverse effects from the molecularly targeted therapies. This slide is it's very basic, and again, I think you all know what molecularly targeted therapies are, but as an educator, I like to make sure we're all on the same page, just you never know who's in your audience. Small molecule drugs obviously act directly inside the cell, and the monoclonal antibodies cannot penetrate the cell surface, and so can penetrate the cellular membrane, therefore act within the cell surface or on the areas outside of the cell. There are numerous small molecule and monoclonal antibodies, obviously. This is just a very tiny slice of all of those that are affected. So this is randomly selected list from many. And as you can see over here, we have how does this little clicker work here? Pardon me, got to go backwards. I like these point up. There it is. So you have trastuzumab, vernistat, bevacizumab, sunitinib, and so we have many different targets on these cells. And I think it's nice to know, but not need to know information. The purpose of this talk is not to go into each of these drugs that I think you are very all comfortable with, but really to focus on cardiac and pulmonary toxicity. So in terms of cardiotoxicity, obviously that's a general term that describes the broad range of adverse effects that can affect the myocardium. Many of our molecularly targeted therapies will definitely cause side effects such as heart failure, LV dysfunction, conduction abnormalities. And think of the population. Most of us are treating individuals who are of advanced age, and so baseline, they will have comorbidities and cardiac abnormalities, and many of them will have hypertension as well. The angiogenic inhibitors, you know, and we'll talk more about the QT prolongation and the risk of sudden death from torsades. And of course, we all know, though, that if a cancer is incurable, then oftentimes the risk of cardiac toxicity will outweigh the safety risk. This is a nice slide that I had taken from a journal Annals of Clinical Oncology, and it is really nice, and it shows the different drug classes and the effect on the myocardium, or in terms of the cardiotoxicity. So you can have acute coronary syndromes from the VEGF targeting agents, QT prolongation from your HERE family, the LV dysfunction and heart failure. Again, most of these are the anti-angiogenic compounds and VEGF, and then hypertension as well, and we'll go into these. So the kinase targeting agents can definitely affect the cardiac function, and there's a thinking that there's an overlapping of the signaling pathways which affects the growth of the tumor cells, and which is important in cardiac homeostasis. One of the questions I'm challenged with, which is in our objectives, is a hypertension a good thing, and should we treat it? Who thinks hypertension is a good thing? Oh, we got one. So we have a taker. I would like to say that I would prefer not to have hypertension in my patients. Long term, we are creating a lot of cancer survivors these days, and treating the hypertension obviously can prevent you from having acute short-term as well as long-term side effects. And as you can see on this slide, some of the poorly controlled factors of hypertension includes the cardiovascular events, stroke, renal disease, and definitely can lead to discontinuation of the anti-cancer therapy. We all know how blood pressure is regulated in cardiac output as well, and there are really no specific recommendations to treat blood pressure elevation. In patients with bevacizumab, there was a study that showed that about 15 to 30% of patients will require antihypertensive therapy de novo from elevated blood pressure. Actually, the severe, from bevacizumab is only like 1%, but this is just an example of how the different drugs can specifically lead to elevated blood pressure. So in general, we look to the guidelines from the American Heart Association, American, College of Cardiology, and in general, stage 1 hypertension is a blood pressure that's greater than 140/90, and we definitely want to make sure that your individual patients are not achieving too high of a blood pressure. So you want to definitely try to target the blood pressure as a systolic less than 200. And again, it's more of a systolic elevation in most of our molecularly targeted therapies and not necessarily diastolic. So again, guidelines are just that, guidelines, and I think it's important to keep that in mind. And we aren't necessarily going to be treating all of our patients, and oftentimes you will have your primary care provider or a cardiology input, but in general, beta blockers, ACE inhibitors tend to be pretty safe. I see Amy Goodrich out in the hall. She's out at 3 o'clock. Just came in, pardon me. Medications that interfere with the cytochrome P450, again, our calcium channel blockers are oftentimes prescribed to treat hypertension, and we need to avoid those in our patients who are on molecularly targeted therapies because the anti-angiogenic substrates can also be in the cytokine substrates. So I think we all are pretty familiar with the QT prolongation syndromes, and that increases the risk of sudden death. The torsades de pointes or de pointe, or however you want to pronounce it, and ventricular fibrillation can occur in many of our patients that have these targeted therapies and predispose our patients to sudden death. Some of the classes of therapies are listed here on the slide, such as the HDAC inhibitors, the multi-targeted tyrosine kinase inhibitors, as well as some of the other ones that are listed here. I think this might not come out very well on your slide, but I wanted to show you an example of electrocardiogram that shows the calculated QT intervals. So you can see on lead 2 over here, you have just a little bit of a prolonged at 559 milliseconds. In this lead over here, you can see the individual goes from pretty much a sinus rhythm to the torsades, goes back into sinus, and then it recurs. And then eventually they can go into torsades and then VFib, where medical intervention is clearly, it would be life-saving intervention at that point. So basically risk stratifying, just like with many of what we do in medicine, is to look at the baseline risk factors. Female gender is something that you can't necessarily change. Diabetes, cirrhosis, and I'm not going to read all of the different risk factors for the QT prolongation that are listed on the slide, but I think it's important to really identify if your patient is at risk aside from the life-saving medications you might be prescribing. So a general recommendation, again, there are no clear guidelines, however, the baseline ECG monitoring 7 days after the initial start of the therapy, especially if the individual is a higher risk group, and then periodically during therapy to kind of gain a glimpse into the QT interval and make sure that there is no prolongation. The baseline QTC, the calculated QT interval, we don't, 470 milliseconds is considered abnormal, 480 in women, and it is recommended actually to stop the therapy or adjust the doses, administer magnesium infusions, and increase the heart rate to shorten the QT interval. So one of the other main things that I consider as a prescriber is to really look at the different medication and drug interactions that you are providing to your patient. So we all know amiodarone and some of the drugs that will be antiarrhythmic that will prolong the QT interval. Some of the drugs such as the serotonin agonists, antipsychotics, antidepressants, something such as chlorpromazine, the ondansetron can actually, as an antiemetic agent, prolong the QTC interval, and some others are listed on this slide as well. So the left ventricular systolic dysfunction and heart failure can occur as a side effect as well of the molecularly targeted therapies. Again, our cancer group tends to be older in age, and there are other reasons for individuals to have heart failure as well in cancer. It's also hard as a clinician to really monitor it, and there have been several studies and meta-analyses, and it hasn't really shown that you can reliably, in physical exam in cancer patients, diagnose heart failure outside of like echocardiograms. We have biomarkers such as the BNP, which is myocyte activity. If you have a negative BNP or a low BNP, it's definitely a better predictor, but if it's high, it doesn't necessarily mean anything. Troponin, of course, is important for damage to the myocardium, but we don't have a lot of reassuring biomarkers that we can check. The other thing is that your individual cancer patients might have dyspnea from their anemia or different etiologies, pneumonia, pulmonary embolism. So it's not a clear clinical picture. And you can definitely see cardiomyopathy, though, as a result of some of our medications. So how do we monitor LV for LV dysfunction? Again, looking to the cardiac guidelines from the American Heart Association and the College of Cardiology, they have some different benchmarks for the decrease in LV. Again, you want to try to get a baseline, especially if your patient's high risk and depending on the drugs that you're prescribing. But modification of risk factors, if there's a decrease in LV, is definitely important. And in our institution, we definitely get the cardiologists on board as well so that we don't have to manage this alone. If you have an asymptomatic but greater than 50% decrease in LV, this is when the guidelines really recommend adding an ACE inhibitor with a cardiology referral. And if you definitely have symptomatic LV dysfunction, again, your cardiologist is your best friend, and that, it's nice to have a team and a collaborative approach with the cardiologist and the medical oncology team. And beta blockers and ACE inhibitors are definitely used. And remember, calcium channel blockers we have to use with caution as a class when you're using molecularly targeted therapies. And on the slide, it is just showing some of the different interventions, such as surgical intervention, angioplasty and stuff, but that's not necessarily anything that everybody would go through. And again, balancing the comorbidities and life expectancy is really important. My last question that I'm charged with is, who is at risk for pulmonary complications? We have several classes of drugs, obviously. Your mTOR inhibitors can put you at higher risk. Erlotinib-induced pneumonitis has been reported in only about 1%, but it can be severe, and there have been some case reports as well. Bevacizumab, we think, binds to lung receptors. Patients can experience hemoptysis as well. But the incidence differs according to the population in which the drug is being used, in breast cancer, metastatic renal cell, etc. This slide just shows some individual patterns of lung and pulmonary toxicity. Look at this really closely. Maybe there was a question earlier on. But there is oftentimes a nonspecific pneumonitis that occurs with a lot of our molecularly targeted therapies, bevacizumab, temsirolimus, some of the newer drugs to treat hematologic cancers as well as your CMLs. And the hypersensitivity pneumonitis can also occur with some of the same classes of drugs. Just with everything we do. In medicine, we want to balance the risk-benefit ratio. Many cases are dose-dependent, so you can definitely decrease the dose of drugs and make sure that the therapy outweighs the risk of complications. Obviously, the basic history and physical examination, monitoring of the lung sounds and respiratory status at each visit, smoking cessation, because a lot of our patients are still smoking cigarettes, inhalers such as your albuterol as well, and prompt treatment if you have a suspected respiratory infection, and sometimes a drug holiday if your cancer status allows, or dose reduction is really useful. So in conclusion, with the molecularly targeted therapies, they continue to be in drug development, and cardiac and pulmonary toxicities are a very common side effect as well, but they are a benefit to our patients who do experience increased quality of life and survival in most cases, but they're very easily identified and treated. I don't want you to take away from this talk that everybody's going to have cardiac and pulmonary toxicities, but obviously looking at the clinical history, comorbidities, and understanding the drug-drug interactions can definitely be important. Knowledge to these events and prompt education and intervention is definitely important. Thank you so much for your kind attention.